Hi, George.
Hello,
Just wanted to.
Good to see you again.
nice to
Hi.
see you too. How are
Good
you?
to see you.
Not bad. We were worried about you.
Oh,
We are
there's
here.
Jörg.
Thank you. Thank you.
I was in Munich and my train was late, and so but I made it.
Yes, you are here. Thank you so much.
I will just get my earphone.
And we are waiting. Dr. Grimbizis, right?
Oh. Hello to
George.
all of you.
Hello, Jörg.
Nice to see you.
Nice to see you too.
Perfect. Now, better sound.
George, how is everything in there?
Yes, perfect. Thank you. I'm very fine. I'm too busy. I'm traveling too much, and this I cannot work. And this is a problem with all these meetings. So I prefer to be online because then I can work in the meantime. But in fact, we should meet in person. This is also very important.
Definitely. You were in Dubai or not?
I couldn't go because I was in Munich. Because my son, with the family, they had a problem and I had to go there. But I was online with them. I did the moderation of the life surgery, and I had 2 lectures. But
Okay, as online.
yes,
Good. Dr. Pistofidis, how is there?
pardon?
In Athens.
How busy?
Dr. Pistofidis, you are busy?
Well, I'm busy mainly with work here in Athens. I had the flu lately, so it's the first day I'm back to work.
Okay.
But, thank God I've recovered and I'm back to normal. But yes, life is as busy as usual.
A lot of
So
flu
I'm
and
not traveling. I'm not traveling as much as Jörg.
Yes, but
nevertheless, it's busy.
the problem is sometimes you like your friends when they invite you, and you don't want to be unkind, and then you realize that a lot of work.
Yeah.
Hello, Grigorios. Hello, everybody. Good afternoon.
Hi, good to see you on
Hello.
time. You are on time.
I cannot hear you. Yes?
Hello.
Can you hear us?
I don't know why I cannot hear you.
You cannot hear us?
Can you hear us, Grimbizis?
We can hear you. We can hear you.
I cannot hear you. I will try to reconnect because I cannot hear. So I will try to reconnect.
Dr. Pistofidis, Dr. Keckstein, I would like to introduce our society president, Dr. Inceboz. She's in there. She's our new boss.
Hello.
Okay. Hello.
Hello.
Nice to see you. Nice to talk with you.
Nice to talk with you once again. We have met in Istanbul some time ago.
Yes,
Today,
your society is very active. Congratulations. That's really extraordinary. There are not many countries having such a active society.
Oh, it's very nice to hear this. Thank you.
Yes.
Today, Dr. Kale and Dr. Usta supposed to be moderators, but Dr. Usta is on the plane now. That's why Dr. Elter, one of our board members, and he will be moderate with the Dr. Kale for the 15 questions.
Okay, perfect.
And we would like to listen to you. It's very good for us to learn something about adenomyosis. Thank you so much for being here and accepting our invitation. Thank you.
Welcome.
Shalom, England. Good evening, everyone. Welcome to our webinar. dear colleagues. This webinar is organized by the Turkish Endometriosis and Adenomyosis Society. Tonight, we will discuss the subject of adenomyosis with the three of our international renowned professors on endometriosis and adenomyosis. Our guests are Professor Jörg Keckstein, Professor Dr. Grigorios Grimbizis, and Professor Dr. Pistofidis Georgos. We will moderate the meeting with Professor Dr. Koray Elter, who is the board member of the Turkish Endometriosis and Adenomyosis Society. During the panel, we will ask the 15 questions that had been previously prepared about our society, and we will discuss these subjects with our panelists. If time allows, we will ask questions from the audience. Now we will start our webinar after providing short information of CVs of our panelists. The first panelist is the Jörg Keckstein. The CV of Keckstein he's a training as a gynecologist at the University of Ulm, Germany from 1978 to 1984. Specialist and consultant at University of Ulm, Germany from 1984 to 1992. His interested area is obstetrics and perinatology, operative gynecology, gynecologic endocrinology and reproductive medicine, endometriosis and adenomyosis. He has numerous scientific publications about endometriosis and adenomyosis. He developed new surgical techniques and special instruments in minimally invasive surgery and endometriosis. He's the founder and director of the first minimal invasive surgery school in gynecology in Austria. He's the founding member of the ESGA, ambassador of World Endometriosis Society. Currently, he's the head of Endometriosis Center, Austria. Our second guest is Professor Grigorios Grimbizis. He is the director of the first Department of Obstetrics and Gynecology, Medical School, Aristotle University of Saloniki from 2017. He worked as a postgraduate fellow in infertility and endoscopic surgery at the Center for Reproductive Medicine of the Free University of Brussels. His research and clinical interests include gynecologic endoscopy and reproductive medicine, and he has published more than 100 papers in these fields. He is the president of the ESGE and elected member of the Committee of National Representative of ESGR, elected member of the Executive Board of the Hellenic Society of Obstetrics. He is the member of ESGE West Working Group for the recommendations of the surgical treatment of the endometriosis. Our third guest speaker is the Dr. Pistofidis Georgos, studied medicine at the University of Genoa, Italy, and did his residence at Guy's Hospital in London. He worked at various hospitals for a number of years, reaching senior registrar at the Department of OBGYN, Hammersmith Hospital, London. Today, Dr. Jörg Pistofidis is the director of the Department of Gynecology, Laparoscopic Surgery at Lefkos Stavros Hospital. He's a partner at the Gynecology Fertility Clinic, Geneva, and collaborates with Mitera Maternity Hospital. To date, he has operated on more than 3,000 patients with various conditions using laparoscopic surgery techniques such as fibroids, adenomyosis, endometriosis. He has dozens of publications and presentations in international and national journals and congress, respectively, with emphasis on the following topics: laparoscopic myomectomy, endometriosis, and adenomyosis. Now, our panelists are ready. Now, we will move on questions if they are ready about adenomyosis. Our first prepared question is do adenomyosis and endometriosis share the same pathophysiology? The first question is, we are directing the Jörg Keckstein. Stage is yours.
Thank you. First of all, I want to thank you very much, the Society and the Scientific Board, to organize this webinar. And I'm very honored and I'm very happy because this is something which is so important to have more discussion, especially when we have all these very high-level scientific congresses. We have lectures and no time for discussions. And now, today, we are only discussing. This is something, a very new format, which I think is very good to do. So now to your question. the main problem is that we do not have a real idea of what is the only genesis or way of genesis of the endometriosis and adenomyosis. But I'm really follow the recent idea of Leyendecker, who is thinking that adenomyosis may be the cause for endometriosis. So maybe we always looked at endometriosis and we really ignored a little bit adenomyosis over the decades, which has changed now during the last, let's say, 15 years. And for that reason, I believe there's a good correlation, but we are not sure if both entities are the same. But coming from the dysfunction of the uterus with the dysperistalsis and the TIR concept that you have an injury and damage by hyperperistalsis, which leads to functional anatomical change and probably also translocation of endometrium of the basalis. This is one idea, but maybe many patients have hyperperistalsis and they do not get adenomyosis. Probably there's an additional pathophysiology within the cells of the endometrium underlying on the basalis. And one patient who have then the pathophysiologic strategy, I would say, it starts when they're young and it becomes very advanced and very severe after the decades. And for that reason, I personally believe the first step is a dysfunctional uterus, in addition probably with some molecular genetic defects on the basalis. So at the moment, this is my approach from my thinking.
Yeah, thank you very much, Dr. Keckstein. Dr. Grimbizis, what is your opinion about the same question?
I think that there is probably a common pathway between endometriosis and adenomyosis, not in all cases, but in some of the cases. Actually, we have to. I fully agree with George that, we don't know exactly the pathophysiology of both diseases. We have some hypotheses on that. And also, the hypothesis that presented by Jörg is really, I think, the most acceptable. But it seems that even that could not, explain all the cases of adenomyosis, not even of endometriosis. Why in some cases of adenomyosis we don't have endometriosis, and why in some cases of endometriosis we don't have adenomyosis. Of course, we can find adenomyosis more often in endometriosis patients, whereas in adenomyotic patients, we can see also, endometriosis. It seems also that all the cases of adenomyosis are not the same. We know the proposal of Kisi, for example, and also Bazot from France. And this is something that it's accepted also, that we have, mainly two kinds of adenomyosis. The one is the internal or the intrinsic, according to Kisi. The other is external or extrinsic, according to Kisi. Both groups, they have the same opinion. And, the one that is extrinsic is more commonly related to endometriosis, whereas the other one, which is intrinsic, is related, to the trauma of the endomyometrial border. So also we have some recent data on the microanatomy, from Japanese group, and also from Keith Isaacson from America. And we are really start to understand a little bit, the microanatomy and also, the physiology of the endomyometrial border and also, of the endometrium basalis, because actually both diseases, they have, basalis endometrium as in the beginning. This is the starting point. So, for me, in both diseases, in some cases, they have the same etiological factor or the same pathway, but in some others, probably, you know, we can have something different. I mean, you know, and we are in a starting point, you know, of understanding what actually is happening. So this is my view. So there is a common pathway, but not in all cases, and we need more data to see in details what is happening in terms of pathophysiology.
Thank you very much, Dr. Grimbizis. Dr. Pistofidis, do you have agree or disagree with these ideas? What is your opinion about the same question?
Thank you. Well, also, thank you very much for inviting me to this very interesting meeting. And I agree with Jörg that these kind of meetings are very productive for doctors who participate. My opinion is that, yes, there is a common pathway, and I will speak more as a clinician, less as a scientist. And from my clinical observation, we know that endometriosis has different expressions. There is ovarian, there is peritoneal, there is deep endometriosis. And again, with adenomyosis, we have diffuse adenomyosis. We have focal adenomyosis, which again is divided into bigger lesions and smaller lesions, like nodular adenomyosis, which I personally feel resembles in many ways deep endometriosis. So I think if we see certain expressions of these two conditions, the ones that seem to be close to one another is nodular adenomyosis with deep nodular endometriosis. And you find those lesions often in similar areas, like in the bottom side of the uterus or near the rectum. And we know that we both have the same collective cell migration mechanism and the same mesenchymal cell transition mechanism. So I find the connection between these two conditions are the smaller nodular lesions, and I cannot find any direct, or at least a more understandable connection between the diffuse adenomyosis and some types of endometriosis like the ovarian or the peritoneal endometriosis. I think there are different pathways relating to those two problems. So that's my answer to that.
Thank you very much. Dr. Koray?
Yes, good evening. My name is Koray, and welcome, first of all, and thanks to your distinguished contribution. The second question is, what's the best imaging modality to diagnose adenomyosis, ultrasonography or MRI? Or secondarily, are there any situations in which you ask for both of them?
Who should start?
Please, could you hear? Yeah, Keckstein, please. Yeah.
Okay. This is a very important question, and there are a lot of discussions now on that. First of all, we are able to identify adenomyosis very precisely with ultrasound and with MRI, both. Unfortunately, both techniques were developed by two different, let's say, specialists. So we have not the same language, first. So, for example, when we see with the uterus and we talk about the junctional zone, which is a zone defined by radiologists, we do not have let's say a pattern in ultrasound which correspond exactly with that of the MRI. We should know. So there's a description on ultrasound and MRI, and I personally start always with the MRI, always with the ultrasound, because we need it also for deep endometriosis, we need it for planning of surgery. But there are many countries, they don't do vaginal ultrasound, they do more MRI, and we can use the MRI. The advantage of MRI at the moment is it's reproducible. You have all the slices reproduced. You can send it to other patients. At the moment, in centers of excellence, probably ultrasound is very good. In other countries and modalities where the diagnostic of ultrasound is not so good, I prefer the MRI. So this is not a good answer, but in fact, I personally believe that the ultrasound, especially you see the dynamic ultrasound, you can see the elasticity also of the uterus, and you can see the adhesions to the adjacent organs, to the bowel, to the bladder, which gives you much more information. For that reason, I personally believe ultrasound is at the moment the first imaging technique.
Thank you, Professor Keckstein. Yes, Professor Grimbizis, Keckstein said he most commonly uses both of them. What's your opinion about that?
Yeah, I fully agree. I think that ultrasound is a very good tool, but in experts' hands, this is the problem. I think that there is a need of expertise in approaching the uterine wall. So this is a prerequisite, because in the experts' hands, you have a diagnostic accuracy around 80%, and also a sensitivity and specificity around 80% also. So I think it's really very good, but this a prerequisite just to have an expert. So this is the one. The second one, and we have to be very careful on that, is what you are seeing in ultrasound. It's also very important, because if you can see the papers of the Musa group, you can see that there is, let's say, an evaluation of the different signs. If you would like to diagnose adenomyosis, you have to rely the diagnosis only in the direct signs, which is the cysts, the stria, and also, the heterogeneity of the uterine wall. For the indirect signs, you don't have to rely your diagnosis on that. And most importantly, and this is also important, if we are speaking about 80% diagnostic accuracy, we have to know that we lose 1/5 of the patient, and in 1/5 of the patients that we put the diagnosis of adenomyosis, they don't have adenomyosis. So this is something that it's really, we must have in our hands. This means 80% diagnostic accuracy. A paper will come out, about the diagnostic accuracy of ultrasound, leading by Keckstein and Jörg. He did a very good job, with 5 societies, and you will have the opportunity, to see that published, I hope, Jörg. But the problem is that the results, is based, on experts' examination. So for me, the initial tool to diagnose is ultrasound, and mainly 3D ultrasound. So this is the starting point. But if you would like, in bed settings, to finalize the diagnosis of adenomyosis, I fully agree that you have to go to MRI. And also, if you decide to make surgery, in my opinion, you have to do MRI. And you have the MRI inside the operating theater, just to guide you, because it's important to know what is happening. It's proved, actually, that there is a very good correlation between the MRI findings and the histology. And this is something important, when you are, going for surgery in cases of adenomyosis. So MRI, in cases that you have doubts about the diagnosis, you would like to confirm in, settings of ultrasound with not the required expertise, and in cases that we need, to go for surgery. So this is probably, the algorithm that we have to approach nowadays. The patients with, supposing to have adenomyosis.
Thank you, Dr. Grimbizis. And what's your opinion, Dr. Pistofidis, please?
Well, I think my colleagues have exhausted the subject extensively, But what I will very concisely say that MRI is what put adenomyosis on the map of pathology. So that's been the gold standard of diagnosis to start with. But then with the advent of the ultrasound and its accuracy, its analysis, its imaging, and with the experience of the operators, I think the ultrasound over the last 10 years has gained enormous diagnostic potential. So I think ultrasound now is probably the #1 diagnostic tool that we have in our hands, in our office, and that we can work with. I think it's very important for the surgeon who is going to operate on uterine pathology to have his own opinion with the ultrasound. I don't think he should rely on other ultrasound imaging photos from colleagues, because that's what often makes the mistake. He should have an absolute personal understanding of what he's going to deal with. He should see if the problem he's examining fulfills the criteria for adenomyosis, or maybe also deep endometriosis, because sometimes this can be combined in a big proportion of patients. So I think it's very important to have an experienced clinician who is going to undertake the operation or the treatment, and also does the imaging test on the patient he was planning to operate. So, but ultrasound, as far as I'm concerned, I agree with my predecessors, is the #1 tool now that we have in our hands to work with.
Okay, thank you, Dr. Pistofidis. And is the radiologist a member of your team? I mean, are they educated and experienced, especially on endometriosis? Or
yes, this is a very good issue. I would say it's a real issue, even not only in adenomyosis, also in endometriosis. If you have a center where you have a colleague or some colleagues who are well trained and are willing to meet in kind of let's say boards, endometriosis boards, then we talk each other and we discuss the patient. Singular diagnosis somewhere in a radiologist who does not use the setting which is necessary to the right setting with technical setting. So we have misdiagnosed the disease. The same with ultrasound. We have the problem with ultrasound and Grigorios also said it, that with all these criteria which are now published, nearly all patients have adenomyosis in some investigations, and therefore we should be very careful to tell the patient she's got adenomyosis without having real, let's say, strong criteria. And the same for adenomyosis. For example, if the patient has the findings are not very clear in MRI, so this is something which is very doubtful and very dangerous for the patient and for further treatment. So we are still at the beginning, and Grigorios is also chairing a group where we want to come more closer to the disease and closer to precise diagnostics. And probably we need training for that. It cannot be said this is the sign, because, you know, ultrasound is very easy to find the pathology if you have a good machine.
Thank you. And the next question will be asked by Dr. Ahmet. Ahmet?
Yes. The third question is now, is there any strict criteria to differentiate between focal or diffuse adenomyosis with using ultrasonography or MRI? Dr. Keckstein, what is your opinion?
There is no clear description. There are some description which say it's a diffuse, it's more than 2/3 of the uterus, but there is no clear accordance, and there is no consensus on that. And probably, Grigorios, you can give some about that, but for my opinion, we have a description, but no size, no extent, this is different in different classification which already exists. So we have a big problem with that.
Okay.
Yes, I fully agree. As far as there is no a generally accepted classification, I think that there is a gap. I mean, in defining focal and diffuse. The only existing proposal is from Musa, group, and their proposal for the classification, where they tried to define diffuse, focal adenomyosis, and adenomyoma. So there are three different, let's say, definitions for each entity. And this is depending on the extent, as George told, I mean, the extent of the disease within the myometrium, and both, I mean, the walls they are there and so on. So this is the only proposal, but this is coming from ultrasound. Is not generally accepted. So this is the one. The second one, the second point that I would like to mention is that even in cases that we have a focal adenomyosis, I will tell my opinion. I mean, what I'm, let's say, using in mainly surgical cases. So even in those cases that we have focal adenomyosis, always you have, micro disease, also in the other uterine wall. I don't think that adenomyosis in the focal forms are only in this part of the wall. So you have to treat the patient. Of course, you remove the focal part, but you have to have in your mind that the disease is probably there. So this is, I mean, something for me that it's really important, I mean, from my experience all those years. So for me, focal adenomyosis is, the adenomyosis that is only in one of the two, let's say, uterine walls, posterior or anterior, and it covers, less than 50% of this wall. So this is, and mainly this has to come with the needs of the surgical treatment. It's not an absolute, it's just, those cases that I define, let's say, or I accept as focal adenomyosis are those cases that I can treat surgically, I can remove the disease and leave, let's say, the clinically healthy tissue behind. This is something that we have to have in our minds. I don't know, I mean, if George has another opinion, because he has experience also, with a huge experience with the surgical treatment.
Oh, thank you very much. Dr. Pistofidis?
Well, yes, I will disagree slightly with my predecessors. I think that there are some criteria to divide between diffuse adenomyosis and focal adenomyomas. And it's very, very important to understand focal adenomyomas if you intend to operate on these women, because it's the size of the lesion that will define the operability of their condition. So I think it's very important to, if you think that it's diffuse adenomyosis, to have very clear in your mind what you're dealing with. On the other hand, if you have focal adenomyoma, which is less than 30% of the uterine wall, because remember, when you remove adenomyosis, you weaken the uterus, you reduce the uterus, you change the organ and its morphology. So you have to have a very good understanding, especially in women who want to have fertility, that you're dealing with the right condition and that you're operating the right pathology. So yes, as far as I'm concerned, in my practice, we have different criteria. When we look at diffuse adenomyosis, we look at a very different thickness of the wall of the uterus when you're dealing with diffuse adenomyosis, with very vague sort of appearance of lacunae and the striations of the affected uterine wall, compared with the opposite uterine wall, unless the whole of the uterus is affected. And of course, you combine this with symptoms and with the appearance of the problem. On the other hand, if you have a focal adenomyoma, it's more of a circumscribed lesion. It's more defined, with irregular contour, with probably the same lacunae inside its mass, and with the vascularity inside its mass. And again, you can do volumetric measurements and then decide if this lesion can be operated on or whether it's better to treat it medically and do not try surgery. So in my opinion, just to conclude, I think there are some differences, and I think it's very important for the surgeon, again, to have a personal understanding of what he's examining.
Thank you very much. Let's go to the next question, Dr. Koray.
Yes. Sorry, I would like to make a comment on this, because if it's possible, a short comment.
Yes. Yes, sure.
George, I think you are absolutely right. But the question was, are there strict criteria? This is our problem. I fully agree what you said, but at the moment, we have no strict criteria. Let's say for focal circumscribed small lesions for 3 centimeters, no doubt. This is not a discussion. But diffuse adenomyosis, for example, can be only the anterior wall or the complete uterus. And then there are no criteria at which point for infertility, for example, and we will discuss this later, there are no real, let's say, official guidelines which one should be operated or not operated. And this is a big discussion. But in fact, you are right. You as this surgeon or whatever.
I will answer your question later on when we're talking about.
Yes, okay, let's go on. But we have to discuss this. We will discuss it. Okay.
Okay.
Thank you. Thank you.
Dr. Koray.
And Dr. Grimbizis, what's the current medical treatment of adenomyosis?
It depends on the patient. You know, it depends, because actually adenomyosis might be present with abnormal uterine bleeding, with the infertility patient, with infertility and also with pain. And sometimes, I mean, you know, you don't have any symptom. So it depends on the patient that you have in front of you. You can choose, I mean, you know, probably the medical treatment that it's fitted, I mean, you know, to this patient. So if you, for example, I mean, you have a patient with adenomyosis and abnormal uterine bleeding or pain, and, you know, there is no, you know, the woman has her children, then, I mean, you can propose, for example, a Mirena, or maybe you can give, I mean, you know, let's say, GnRH analog, something like that. So this is different. If you have an infertility patients, then, you know, what you can do is just to stimulate the patient, you know, to take the eggs, to freeze the embryos, and then, I mean, you know, to go for a frozen embryo transfer, after, you know, down regulation for 3 or 4 months, just, you know. And also, you know, we had a discussion in Dubai, actually, you know, on Saturday, and it was Fatemi who supports that by giving together, I mean, you know, GnRH analogs and aromatase inhibitors, maybe you can expect better results, because there is a regression of the adenomyosis, more, you know, let's say, pronounced regression of adenomyosis if we give together with GnRH analogs, you know, aromatase inhibitors, because in this way you prevent also, you know, the estradiol levels coming from the ovary, but with aromatase inhibitors, you prevent also, you know, the local action of, you know, of the estrogens. But this has to be proved, because there is just only one paper. He supports that he has very good results, and I told him we are waiting for his, you know, let's say, publication. So those are the medical management that we can do. I mean, and also for pain, you know, of course, we can use painkillers, but on the other hand, you can use also Mirena, who might help the patient. For GnRH analogs, you cannot use GnRH analog, you know, for long term, because it's actually, you know, menopause, so there is a problem. On the other hand, another, you know, medical treatment that we can try, if we suppose that adenomyosis and endometriosis have a common pathway in some patients, then we can use diagnose, I mean, you know, for the symptoms. This is something that we can try also. There are groups that they support that they have very good results, others, that they don't have very good results, but those are the medical tricks that we can use for patients with adenomyosis. So if aromatase inhibitors, it will be proved that it will work, maybe this is a very nice tool, but we have to see together with them.
Thank you, Dr. Grimbizis. And Dr. Pistofidis, what are your comments?
Well, I think Dr. Grimbizis is absolutely right. I think what decides on the treatment is not a disease, but what the patient wants and what the symptoms are. So you have to start whether the patient is in pain, whether she's bleeding, whether these are not the primary symptoms, but she has adenomyosis and wants fertility. And according to what the requirements of the patient, you have to just create the treatment around her, what she needs. So, like he said, if you have dealing with diffuse adenomyosis and she wants fertility, then you have to think along the lines of GnRH with aromatase inhibitors potentially or without, and then offer them IVF, which gives them the best possible outcome. If you're dealing with somebody who is not asking for fertility and she's older, then you can think of Mirena, which is the intrauterine device, levonorgestrel IUDs, and then decide maybe even on long-term treatment with antagonists, like the newer medication which combines with estrogens and progestogens. So you have treatment options depending in what sort of situation you're dealing with.
Okay, thank you, Dr. Pistofidis. And Dr. Keckstein, any more comments?
No, I think I can follow my procedures, and we know that it's a estrogen-dependent disease. That means we are modulating the estrogen level, and by several medications, and it depends also from the situation of the patient. Long-term treatment or infertility treatment is very individual, but still we're working to reduce the influence of estrogen. This is the most important, let's say, treatment which really treats the disease and not symptoms. In case of activity, we do not reduce it. It's impossible at the moment, since if we can destroy adenomyosis, then we will destroy normal endometrium as well at the moment.
Okay, thank you, Dr. Keckstein. And Ahmet, it's your turn.
Yes, thank you very much. The next question is, does surgery of adenomyosis before IVF increases the pregnancy or live birth rates? Dr. Keckstein, let's begin with you.
So, this is this big discussion, since we know from many IVF centers that they don't describe the adenomyosis, and during the last, let's say, 10 years, it's respected and reflected that adenomyosis reduces the IVF transfer rate or the implantation rate. This is obvious according to the number of ultrasound signs. There are a few papers on that show the more advanced adenomyosis, the more you have failure in the transfer. And so for that reason, I think we might have the possibility by reducing focal adenomyosis, but also diffuse adenomyosis for the fertility to increase the fertility rate. But on the other hand, surgery means risks, and for that reason, I personally always decide to have patients in IVF before I do any surgery, except the patient is suffering from extreme pain. Then you have to do surgery. But we know that this peristalsis is clear in adenomyosis, and then the sperm transport and implantation is disturbed.
Okay, thank you very much. Dr. Pistofidis?
Well, I totally agree. I think untreated adenomyosis, untreated, there is no doubt that reduces IVF results. There is no doubt about that. Also, that operated adenomyosis increases the fertility of the patient. The question is, which ones do you choose to operate and which ones you avoid to operate? This is the key question of this point. And I think with diffuse adenomyosis, you are stepping on very thin ice because you can really damage the peristaltic mechanism of the uterus. You can cause problems with the continuity of pregnancy. It's a dangerous situation. I personally do not support surgery with diffuse adenomyosis for patients who want IVF. I would rather treat them medically, like we said earlier. With focal adenomyomas, yes, I will select which patients are good to have surgery, and then I will proceed. And definitely we see better results after that kind of surgery, especially when the focal adenomyoma affects the endometrium, when there is distortion of the endometrial appearance. In those particular cases, I think there is definite improvement and better outcome. That's my answer.
Okay, thank you very much. Dr. Pistofidis? Excuse me, Grimbizis, excuse me, Dr. Grimbizis, yes.
I think that I will make just some, no, I fully agree with the previous, speakers. So for me, surgery should be the last option. Laparoscopic surgery, abdominal surgery, should be the last option. We can apply surgery in cases of focal adenomyosis. In cases of diffuse adenomyosis, you have to be very skeptical because all the operations, they are really very aggressive. So you have to apply only in cases of failed repeated implantation in these cases, and where actually all the other medical, management, fails to give you a pregnancy. So this is the first one. Concerning, let's say the adenomyosis that has to do with the endomyometrial border, because sometimes we can see small cysts there, or adenomyosis affecting, part of, the inner myometrium. Then, in selected cases, and in very, in the hands of experts, you can apply hysteroscopy. So this is where we are. So be very careful, with the operation of infertile patients. First choose, the medical management, and then go for surgery in very selected cases. So concerning the results, what we know is that if you apply surgery, you have, pregnancy rates that, in reviews that we have in the literature, after surgery, you have, a pregnancy rate between 30 and 50%. So this is what we know, but we cannot in cases of infertility. So maybe surgery helps in a very selected cases and in the hands of experts.
Well, thank you very much. I think the next question, Dr. Koray, let's move on.
Okay, thank you, Ahmet. Once you decided surgery for diffuse adenomyosis, what type of surgery do you prefer? Laparoscopy, laparotomy, and the technique, please. Pistofidis, Dr. Pistofidis, please.
Well, I already have answered that question in that I do not operate on diffuse adenomyosis by either way, laparotomy or laparoscopy. So that's nothing that I can answer about. But I would only do laparoscopy for very, very selected cases of focal adenomyomas. So that's my answer.
Thank you, Dr. Pistofidis. And Grimbizis, please.
So for, cases of focal adenomyosis, I'm using the classical technique. It's like the technique of adenomyomas, of myomas. So you remove adenomyomas.
What about diffuse adenomyosis?
So for diffuse adenomyosis, only very selected cases, and you can use either the overlapping technique. The Osama technique is very aggressive. I'm not doing that. I prefer to make partial adenomyomectomy if I decide to operate in cases of diffuse adenomyosis. I don't think that we can, excise the whole adenomyotic tissue. It's a cytodeductive surgery. And in these cases, my preferred technique is the overlapping technique. So if you do this by laparoscopy or by laparotomy, I start with laparoscopy, but this is not the question. You have to do the best for your patients, either open or laparoscopy, depending on your skills. So,
thank you, Dr. Grimbizis. And Dr. Keckstein, any more comments?
Yes. The main, let's say, issue is it's not a question to remove something. It's a question what you leave behind. This is the most important thing. Removing is easy. You can do it whatever you do. The question is, how is the function of the uterus after restoring it? And since we know it's an aggressive surgery, we should reduce all problems which may interfere with the healing process and for further pregnancy. So when you have, for example, a focal diffuse adenomyosis or diffuse adenomyosis on the anterior wall, you may do it endoscopically, robotic assisted, but you have to be sure that you have removed as much as possible. You have to be sure that what you leave behind, there is no adenomyosis or little adenomyosis. For that reason, in infertility patients, I often decide then to do open surgery. Since I was trained in microsurgery and I have my fingers, and with the fingers I can feel the uterus, I can feel where is the nodule, where is the rigid, and where is the soft tissue. Then, in addition, the cavity, sometimes you are coming close to the cavity, then you have to put a balloon. I mean, you can do this all laparoscopically. I'm addicted to laparoscopy, but this is an indication still for open because we have only one chance. And we have responsible for this uterus. And to say also to George, the main problem is the big diffuse global uterus, they will never become pregnant. And for this, there is an indication for the OSADA procedure because the alternative is hysterectomy. And when they have 10 IVFs and it didn't work, they wait until they are 38, 40, and then they come for surgery. Then the result of surgery is very bad because of the egg quality. So we have to find out in future that people should go very early in IVF. And if you feel this uterus will not become pregnant, then the next step could be surgery.
Can I
Thank
make
you
a
for
comment? Can I make a
please,
comment on
please.
Well, it's my turn now to make a comment. Well, I mean, we have to remember that we live in a very medico-legal era where things can go very, very wrong very rapidly.
Yes.
So we have to think carefully consequences, not only operability, but consequences. We're dealing with young women, with healthy otherwise women who want a child. And things can go extremely wrong in these patients if we don't make the right decision. So that's, I rather have an intact uterus with medical treatment, even prolonged medical treatment with aromatase inhibitors or intralipid infusions, whatever, but try to do a conservative therapy rather than take the risk to remove either too much or suture affected areas and then risk some kind of complication later on. So that's why I believe that operating on diffused adenomyosis, you have to know exactly what you're doing and how you do it.
Yes.
Be very careful about the follow-up.
But another answer is you can have a rupture of the uterus only without any surgery if you leave adenomyosis behind. And there's many reports on that. And I have also 3 patients. And in addition, it is also you are responsible for the patient if you go on with IVF and treatment and treatment and treatment, and finally she will never get pregnant because you didn't offer an alternative. This is also responsibility.
If you know, you may allow a comment. I think that
please.
We all agree that, you know, the surgical treatment is the last choice.
Yes.
I don't think that there is anybody in the panel that, you know, has the surgical option as the first point. So we are discussing about patients with failed probably IVF, failed implantations, and then we have to decide what to do. If we can help them, I mean, you know, with aromatase inhibitors or maybe GnRH analogs, there is no discussion that we have to do it with that. So we are discussing, you know, for desperate patients that they cannot succeed what they want, I mean, you know, with other way. And, you know, for those cases of diffuse adenomyosis, we are not speaking about small uterus.
Yes.
So they have also a health problem. My view is that the cases of diffuse adenomyosis, that they have infertility, they suffer usually also from pain and also, you know, from abnormal uterine bleeding. They don't have only infertility. You know, patients with you know, a uterus, a very large uterus, affected by adenomyosis, they have other problems also. And if you see the guidelines of ESRE for endometriosis, for example, in cases of infertility, and you know that how conservative they are, of course, probably this is my view also. You know, in cases of endometriosis with pain, if you have another symptom, you have to think about surgical treatment. So it's not easy. But you know, the starting point is always, medical treatment.
Yeah.
Thank you for your distinguished comments. And the next question, Ahmet, please, it's your turn.
Yes. The next question is the 7th question. When do you decide to perform surgery in infertile patients with adenomyosis? Let's begin with Jörg Keckstein. Yes.
Nothing to add. We did it already. I mean, we said it, for my opinion.
Okay. Dr. Pistofidis?
Well, I think I agree with Jörg. I think we've more or less exhausted this point with previous discussions. So I think we know already the answers to that. So I think we should really go ahead with the next one.
Okay,
Ahmet, then let's move to
Dr. Grimbizis,
next question.
I want to ask the same question to the Grimbizis. Yes.
No, I think that we had a big discussion previously, you know, answering this. I mean, you know, surgery is the last option. So I don't think that we can continue on that. If there is a question from the audience, we can, you know, let's say.
Okay. Dr. Koray, Elter?
Yes, next question is, if progestin therapy fails for diffuse adenomyosis, what's your second option? Dr. Pistofidis, please.
I mean, the question is, would I give progestin therapy to a woman with adenomyosis? Well, let's say that, yes, I used progestin therapy. I mean, the question is, again, what is the purpose of the treatment? Am I treating pain? Am I treating bleeding? Am I treating fertility? Or simply a patient who does not want to have surgery? Because some patients do not want to have surgery, in which case, when we have to think what's next. For instance, if progestin therapy has failed and the patient does not want fertility, and she's bleeding and she's in pain, then laparoscopic hysterectomy is the answer. It's a straightforward answer. If the patient does not want fertility, but refuses surgery, you have one of these difficult cases, then I would try with levonorgestrel, intrauterine device, IUD, or long-term treatment with an antagonist. And finally, if I have not tried oral antagonists or any of the two, then potentially just try something else, like, GnRH agonists or oral contraception, whatever. But, mainly surgery will be the answer, hysterectomy in these particular patients.
Okay, thank you, Dr. Pistofidis. And Dr. Grimbizis, please, any comments?
Yeah, I think that, as mentioned before, we have to see what patient we have in front of us, what is the symptomatology. So in cases, you can use, progestine, for the treatment, like, let's say Diagnose. And if it fails, you can use a Mirena. Or if we have infertility patients, maybe aromatase inhibitor. We are speaking about aromatase inhibitors, but there is no still evidence that we have a result. It's probably a good option, but we have to wait. You can try that, let's say in a research base, it's a very good idea. But we have still to, to wait for the results. For the others, I fully agree, with, Jörg Pistofidis. I don't think that I have something more to add. It depends on the patient, and, we discussed before, what for me is the algorithm of, the treatment.
Thank you, Dr. Grimbizis. And Dr. Keckstein, please.
Yes, progestine works very well in many cases. Sometimes the dosage is not enough. We have to increase it, and this is sometimes a problem. And in that, maybe it could be helpful to add estrogen to stabilize the endometrium, because these patients have bleeding disorders, and they get spotting, and they get bleeding problems. And then my next step is always GnRH analogs in interval or antagonists at the moment, which is now coming more and more. And with aromatase inhibitors, I have not real experience. This is for me at the moment experimental and in a scientific phase at the moment, for my opinion. And Mirena is also progestine, and for that reason, my alternatives are very little, but it depends if it's pain, infertility, and for me it's important, for example, in infertility, but the question will come later, that the downregulation after surgery or after stimulation could be helpful, not giving the embryos immediately back after stimulation, that the uterus can calm down.
Thank you, Dr. Keckstein. Yeah, please.
A final comment, because Jörg Pistofidis, mentioned about, the GnRH antagonists, the oral ones, which probably might be helpful, because there are some publications on that. Initial publication mainly from the company. In that case, I would prefer to give GnRH agonists, which are the normal ones, with add-back therapy. So if the woman do not want to be operated, and he has, to make an hysterectomy if he finished, with the children, or you would like to stabilize the women with diffuse adenomyosis until she wants to have, let's say, the children, an alternative might be GnRH agonist with add-back therapy.
Thank you, Dr. Grimbizis.
Like for example.
Okay, thank you. And next question, Ahmet, please.
Yes, the next question is, when do you use hysteroscopy for adenomyosis cases, or do you use hysteroscopy for adenomyosis cases? Dr. Keckstein, what is your opinion?
Yes, Grigorios already mentioned this. If you have circumscribed areas, superficial, we call it superficial adenomyosis underlying the endometrium, the cystic ones, or obvious, good, reachable lesions which are not intramural, I would do it by hysteroscopy. There's some data that you can do also adenomyomectomy via hysteroscopy, but you have to be very well trained. And the main problem is that you may do a stereoscopic or not stereoscopic, a simultaneous ultrasound when you resect the adenomyosis to be sure that it's complete. but this is something which is good for selected cases.
Do you have any cutoff size, for example, for something?
I mean, for, let's say, if the patient does not want to become pregnant, though I would say 2.5 centimeters would be a size which is good resectable. But in case if you have a infertility patient and you want to make a hole 25 millimeters, this may disturb the cavity and the pickup, not the pickup, the implantation process. And there I would be very restricted in the indication, do it through hysteroscopy.
For infertile patients, the cutoff limit is the 25 millimeters, as far as
3 centimeters, yes, but they must be circumscribed, not a diffuse one.
Okay, thank you very much. Dr. Grimbizis?
For those cases of focal adenomyosis, I would prefer laparoscopy. I mean, if there are 3 centimeters, I mean, even if it's if it's very close to the junctional zone, I feel more comfortable. Yes. And I avoid, the trauma of the endometrium.
Yes.
But I'm not sure what will be, the result in the endometrium after extent hysteroscopic surgery, because we remove also myometrium. So this is for small cysts that are subendometrial cysts. I prefer hysteroscopy. This is clear. You have to open and also to remove the adenomyotic, let's say, tissue, which is something that could be done with hysteroscopy. And for me, there is another place of hysteroscopy. If you suspect adenomyosis with ultrasound, for me, there is an indication to make hysteroscopy to see the endometrium and what is the effect of adenomyosis in the endometrium before the embryo transfer. Because this might be a criterion, for medical treatment or medical management of these patients. Instead of putting back the embryos, I mean, in a normal cycle, it's probably better to downregulate and then to prepare the endometrium after downregulation. So if we have signs of adenomyosis, during hysteroscopy, I mean, you have to decide a different embryo transfer policy. And in all cases that you suspect adenomyosis, it's preferable, to do an hysteroscopy to see what is happening in the endometrial environment. So it's not what you operate, but what is the place of, of hysteroscopy in infertile patients. And also, that, when you are dealing with patients with infertility, the normal concept is that 45% of them, or maybe 40, it depends, has male factor infertility, 45 female factor infertility, and there is a 10 or 15%, depending, I mean, on the centers, the so-called unexplained infertility. So we have, to be very careful when we are speaking about unexplained infertility. Look in details your uterus. Maybe there is something that we are missing. And then, I mean, if you support the women in the right way with ultrasound, with an experienced or MRI, if you have failed implantations in these cases, infertility, long-standing infertility, see the uterus in the detail. Sometimes there is no need the uterus to be large. I mean, you can have signs. There is a question also, if you have, some direct signs, if this is adenomyosis in ultrasound into yes, look in details. If you have, direct signs, manage, the infertile patients in the right way.
Okay, thank you very much. Dr. Pistofidis, do you have any other comments?
Well, I think Dr. Grimbizis has said it all. I mean, he's given a complete picture of hysteroscopy. I only think, I just want to emphasize that especially in women who want fertility with adenomyosis, I think office hysteroscopy is important to assess the endometrium prior to decisions, whether this is surgery or whether this is IVF, because you can gain more information about how to manage whether to do surgery or whether to treat this woman medically prior to treatment, to IVF treatment. So in these particular cases, I think, yes, office hysteroscopy has a very strong place.
Yes, okay. I agree.
Thank you very much. Dr. Prof, please move on to the next question.
Okay. Dr. Keckstein, please. Is there any connection between focal adenomyosis and infertility?
Yes, that's what we tried to discuss, and it's not only a question of type of adenomyosis, it's also a question of size and extent. Focal, what is focal? 5 millimeter or 5 centimeters? We have no definition concerning that. So probably if you have a very small lesion, I think the impact on infertility would not be so clear. But if these are lesions bigger than 2.5, 3, 4 centimeters, I am absolutely sure that the peristalsis and the uterine function is disturbed, like with fibromas as well, but with adenomyosis more. So there is a correlation.
Thank you, Dr. Keckstein. And Dr. Grimbizis, please.
So if you see to the publications, you can see that in cases, you have publication for the effect of adenomyosis on fertility, the different, let's say, studies have different results. Some support that there is an effect, some others that there is not. Some others, they support also, that there is an impact in the evolution of pregnancy in terms of miscarriages or preterm delivery, and also, preterm rupture of the membranes and so on. So the problem is that in the absence of a clear categorization in all studies, and as far as we don't have a clear description of the patients, we don't know what type of adenomyosis, has any effect, on fertility, on implantation, or in the evolution of pregnancy. The fact is, from the recent research data, that there is a change in the microenvironment, of the endometrium basalis and also in the junctional zone. And those are, coming, as I told in the beginning, for the pathogenesis from some Japanese group, and also in the States from the KT section group. And also there are data from Katerina Exakustos that, they were, she published the data in fertility sterility, that there is a problem in the placentation, the evolution of pregnancy. So I think the changes in the microenvironment of the endomyometrial unit, has an effect, of course, in the evolution of pregnancy and in the achievement of pregnancy. So what we have to clarify is, and this is, we need a classification that has to include not only the extent of the disease, because here we are speaking about focal and also, diffuse disease. But this is not the case only in adenomyosis. That adenomyosis, they have, both a glandular element and also, a muscular element in terms of hyperplasia. George Pistofidis published, the data about the different types, the sclerotic type and so on. And there is a big discussion also, and if you see the proposal of classification by Musa, they also mention, what is the pronounced, let's say the glandular or maybe the myometrial element of the adenomyosis. And this might have as a result, a different clinical implication of the existing adenomyosis. So it's not only the extent. If you have focal or if you have, let's say diffuse. It's also, the type of adenomyosis that you have. It's also which part of the myometrial wall is affected. If it's, the internal part or, let's say the external part. Of course, according to Musa, they divide in 3 parts, but I don't agree. So also this might play a role, because if we have the, let's say the external part, we have to discuss if this has an impact, in the achievement of pregnancy or in the evolution of pregnancy. So there are questions. What is clear in general is that adenomyosis, independently if it's focal or, it's diffuse, has an impact in fertility and has an impact in the evolution of pregnancy. Which type? We don't know.
Okay, thank you, Dr. Grimbizis. And Dr. Pistofidis, any more comments, please?
Well, yes, there is a lack of large prospective trials to assess the impact of focal adenomyosis. And I think it's not just a question of measuring in centimeters, but volumetric measurements. Adenomyosis is not something that you can measure in 2, 3, 5 centimeters and then decide whether it's bad or good, or you can avoid it or go ahead with surgery. I think it's a matter of volume of the lesion in comparison with the total volume of the uterus that you're dealing with. So volumetric studies have to be implemented in organizing such studies. It's very important to see if this lesion is affecting the endometrium, and if there is an impact on the endometrial integrity, then again, that will affect fertility. And finally, something that we have not discussed is CA1 to 5, because often CA1 to 5 is raised in these patients. And we also have to take that into consideration, because if that's raised, maybe there is also other factors involved in her infertility, maybe also endometriosis to some degree. So I think we have also to consider not only size of the lesion, but also biochemical results in deciding whether this lesion is affecting fertility or not. So that's my answer to that.
Thank you, Doctor.
I would like to make a comment
on
this.
Please.
Thank you very much, both of you. I absolutely agree. And when I said 2 to 3 centimeters, it was not the size what I wanted to fix as let's say the limit. I just wanted to explain that and that's what George also said, it depends on the correlation and the ratio between healthy and pathologic tissue. This is very important. And when we look at the data which Grigorios mentioned, that there's not clear. When you look into these papers, they even didn't make groups. What was the type of adenomyosis? Was it diffuse? What is 30%, 80%? And then we compare only the outcome of pregnancies, but they did not make a good, let's say, prospective, what George said, a prospective evaluation of very similar groups concerning the pattern, concerning the pathophysiology, concerning the CA12-5. So this is missing, and I agree we should be more precise in future to find correlations. Thank you.
Thank you, Dr. Keckstein. Yes, Ahmet, please.
Yes, the next question is, what are we going to face during the follow-up of a pregnant woman with adenomyosis? Let's begin with Pistofidis now.
Okay. Well, I'm very lucky because I don't do obstetrics anymore, so I don't have to worry about follow-up. But to be serious, the question is operated or non-operated adenomyosis? Because if it's a case that has already been operated, then depending on the remaining volume of adenomyosis, that's very important to know how much is left behind. In this particular case, miscarriage, premature birth, incompetence, cervical incompetence, abnormal placentation, and God forbid, uterine rupture and postpartum hemorrhage. I mean, these are the problems with operated patients. So one has to be very, very careful. Non-operated patients, again, it depends whether you are dealing with diffuse adenomyosis and large focal lesions. And again, the risks are miscarriage, premature birth, and postpartum hemorrhage. So I think adenomyosis is a very tricky condition. One has to be very serious and very careful about how to monitor these women. And there has to be a direct communication between the people who do the surgery and the obstetricians who will take over the follow-up of these patients. We always give to women that we operate adenomyosis a small card which we explain exactly what we've done to give to the hands of the obstetrician and point out the importance of the surgery that we've performed. So that's my opinion.
Okay, thank you very much. Dr. Grimbizis, please.
I think that George, described, very, extensively all the complications that, we might expect from an operated patient or an non-operating patient. So I think patients that they are not operating, both of them, they have to have a very strict follow-up and about the risks, and also, with ultrasound follow-up, mainly, during the second trimester of pregnancy, mainly for the placentation, for the risk of rupture, and also, for the risk of hemorrhage, because those are the most important, complications that we have. And then we can support, of course, with progestines, just for to avoid preterm delivery. There is no proof that, there is something that might help, but if in general, for preterm delivery, we use progestines to prevent, this might be used also in cases of adenomyosis. And of course, we have to look very carefully for the potential risk of rupture.
Thank you very much. Dr. Jörg Keckstein, do you have any comments?
I can just confirm what George and Grigorios said. There is another, what I said what I mentioned is the rupture in unoperated women. We have, I know 3 patients, they had it, and it was dramatically. Also, and it depends on the adenomyosis. So if a patient becomes pregnant with adenomyosis, we should follow her and we should inform her probably that there is a little risk, not very high, but it exists. And after surgery is clear, we should be very, very close to the patient to understand if there's any disturbance or any, let's say, complication coming. We should be aware, and the patient should be informed about this.
Jörg, can I ask you something, please?
Yes.
You just mentioned that you know of 3 cases of non-operated adenomyosis that ruptured the uterus.
Yes.
Can I ask you, in these particular cases, did they have some other type of treatment, like an artery embolization or
nothing.
MRI focused something?
They had nothing. They had nothing.
Okay.
It was a decellularization of the uterus.
Okay.
It was a special type, a special, let's say, histologic type. When we cut out a piece, in one patient, we removed, I know 3 patients. 1 happened in our hospital, and 2 patients came afterwards to repair the uterus, to cut out the adenomyosis, because she didn't want to become pregnant again without having removed the tissue. And then the histology shows and that's what you said, the type of adenomyosis full of glands, little fibrosis. And so the uterus became decellularization, and the microfibrils of the myometrium are very, very weak. And by distension of the uterus, they ruptured. But these are very selected cases. But I looked now in literature, there are many cases reported.
So
also,
that's abnormal placentation, basically.
Yeah. Maybe, yes.
Penetrates within the adenomyotic.
But that's what we don't see.
Yeah, but
I think this is very special, and we should encourage people to follow these patients, become with let's say with diffuse adenomyosis and with ultrasound to see what happens in the diffuse adenomyosis. We do not have much data on this. How do they change in their sonographic pattern or MRI pattern?
But If you allow me a comment, this.
Yes.
This underlines, the fact that the different, forms of adenomyosis, if the glandular, element is more pronounced, or maybe the muscular element is more pronounced, has to do with the function of the uterus. And this is something that we have to, to take into account. When we are speaking about cases of adenomyosis. And this also underlines the fact that abnormal placentation might be responsible, for the pregnancy losses, early miscarriages, or later, for abnormal placentation and, let's say, abnormal behavior of the uterus, as George described, previously. So this is something that, we have to take into account when we are, let's say, dealing with patients with adenomyosis.
Thank you very much, Dr. Koray. This is your
Yes,
turn.
the next question is, what's the place of Mirena in women with infertility? Dr. Pistofidis, please.
Well, I think there is some data about LNG-IUD before IVF treatment in women who are specifically going to have in vitro fertilization treatment with diffuse adenomyosis, potentially. I have not tried it myself, but there is data to support that pre-IVF therapy with Mirena IUD can enhance embryo implantation. I have not tried it. I'm not in any way expert with this principle, but it has been published. Of course, young women with infertility who want fertility, it would not be my first choice. I would not propose an LNG IUD in younger women with infertility. I would only offer it to women who have more or less exhausted natural trials and are going for in vitro fertilization. That's my opinion.
Okay, thank you, Dr. Pistofidis. And Dr. Grimbizis, please.
So this is not also my preferred method. I prefer, let's say, the long down ligation with GnRH analogs just for embryo transfer. But, an idea is just to use Mirena for, let's say, 6 months. There is proof that the use of Mirena decreases the volume of the uterus. If you put it in for 2 years and, fails also, to, let's say, to control the process of adenomyosis after 2 or 3 years. So if we are speaking about infertility patients, IVF patients, and you are in the process of freezing the embryos, maybe just putting an Mirena and try, an embryo transfer afterwards. It's not, an idea that we can exclude, but only in IVF patients, and also, when you are in the process of freezing, the embryos.
Okay, thank you, Dr. Grimbizis. And Dr. Keckstein, please, any comment?
Yes, I do not personally have a lot of experience with patients who won't become pregnant at the moment. I personally believe this could be a very good option in younger women, and we have no many data on that it could protect the aggressiveness of the adenomyosis in future infertility. But I have no personal experience with that, so I cannot give you a good answer on that.
Yeah, thank you, Dr. Keckstein. And Ahmet, please, next question.
Yes, the next question is that if we perform adenomyosis surgery, when should we allow pregnancy? 3 months, 4 months, 6 months, or 1 year? What is your opinion about Jörg Keckstein? Yes.
Yeah, I at the moment, I personally say 6 months, but there are no data because the numbers of surgery and follow-ups are not so good to be scientifically relevant. I do it very similar after myomectomy, but I'm sure that the healing process could be longer, but I would not do it shorter than 6 months.
At least 6 months, yes. Dr. Pistofidis?
Well, I do not perform surgery for diffuse adenomyosis, so that does not affect my decision for that particular problem. Now, when I operate for focal adenomyosis, I see all my patients 3 months after surgery and assess the thickness of the myometrium and the vascularity of the myometrium. And then I see them again at 8 months after surgery. My advice to my patients is to wait for 8 months until I see them again. So I give them an 8-month distance from going ahead with either natural fertility or IVF. And I'm always checking at the thickness of the myometrial wall and the vascularity of the myometrial wall. These are my criteria. So
why 8 months instead of 6 months? What is
because I feel this is my personal feeling that with myomectomy, because the myometrium is more or less intact, the length of time does not need to be that much. I think 6 months is probably more than enough, even if you remove 5 or 6 myomas.
Yes.
But if you're dealing with adenomyosis, because you remove part of the uterine wall, my feeling is you need longer to be happier that the healing has been completed. So as far as I'm concerned, I differentiate the length of time between myomectomy and adenomyomectomy. So I think 8 months is my cutoff point after adenomyosis surgery.
Yes, your personal experience. Okay. Dr. Grimbizis?
I think that there are no data, about the length of the, of the time that you have to wait for the future pregnancy. If we go to myomectomy and you see, the results in uterine rupture after myomectomy related, to the time that you achieve the pregnancy, there is no correlation between the time that you achieve the pregnancy, the surgery, and also the time that you wait, and also the risk of the rupture. There were ruptures, let's say that the women waited for more than 1 year. So there is no clear correlation with the time. If you are going to a normal healing process, to a normal one, we know that the tissue, after healing in 1 month has the 99% of the strength of a normal tissue. So for myomas, let's say we have to wait maybe 3 months, maybe a little bit more for adenomyosis. But for me, the most important parameter that we have to take into account is what type of surgery we did, because if we, remove a focal, let's say lesion, maybe, the time that you need is less than, if you have a more extended surgery to the uterus. So this is the one. The second one is the appearance of the uterus, and also, in ultrasound or in MRI, if you would like that to check more in details, and to see if there is a defect in the healing process. This is important, because in case of meiosis, as far as you remove myometrial tissue, sometimes you have defects. And in these cases, you have, to give more time, or maybe you can advise to avoid, pregnancy afterwards. It's like, removing, let's say a lot of myomas, where you have to wait until, let's say the uterus. I have cases, and I did MRI, let's say in 4 months, and then in 8 months, and then in 1 year, seeing what is, the healing process in the myometrium. So this depends on the type of the, surgery that you did, and also the extent of myometrial tissue that you remove. So it's not a straight answer on that.
This is a very good description. I tell you something. Many years ago, I think 25 years ago, I did a patient with 30 myomas. I did open surgery. I removed it, and I forgot to tell her not to become pregnant after surgery. And she became immediately, the next ovulation, she became pregnant. and I was dying nearly. And I did then I did this, the cesarean section, and it was nothing to see. This was very interesting. These were 30 myomas. And I had one rupture after myomectomy, a patient, where I did a 3-centimeter intramural fibroma, and she became a small rupture in the 36 weeks. She was only bleeding. There was no let's say, emergency in that case, but there was a rupture. So it's absolutely clear, and I agree that it depends on the reconstruction and how the uterus looks like after a while.
I have a very strong objection in this particular area with Grigori, because he reckons that time is not so important, in that rupture can happen even 1 year after surgery or 2 years after surgery. That is correct. But the problem, because I published on uterine rupture after myomectomy, I've looked at various cases of uterine rupture, and I can tell you that the most important factor is how you remove myomas and how you suture the uterus, and how you burn the myometrium. Because I've seen so many of my colleagues doing bad myomectomies with extreme cautery of the myometrium, and that creates very, very weak scars. And those scars will persist 1 year, 2 years, 3 years after surgery. It's nothing to do with the operation. It has to do with how you perform the operation.
We are right.
So this is the problem here. So nobody knows, because every patient heals with a different speed. And this is exactly what Jörg said earlier. This woman became pregnant 1 month after the operation, after 30 fibroids, and she had a C-section at the end. So we are dealing with different types of healing, different speeds of healing, different people. But on the whole, we have to standardize as surgeons how myomectomy should be performed by laparoscopy.
Yes,
but this is very important, and we're not paying enough attention teaching.
Yes, you are absolutely right. But there's one.
I mean, we don't disagree, but I think that the technique, this is what I mentioned. It depends on the operation and on the technique that you did. And this affects the healing process.
But it supports, Osada's data support this, that the cautery. And this is the reason why I make open surgery with cold knives, because I don't want to cauterize the little myometrium we leave behind, because adenomyosis destroys big parts of the myometrium. We lose myometrium. In myomectomy, we never lose myometrium. But in adenomyomectomy or adenomyosis surgery, we lose myometrium.
That's true. And also, if you see to the publications of ruptures, there are ruptures, I mean, in subserosal myomas, even in pediculated subserosal myomas. This means that the surgeon that removed those type of myomas, we are not speaking for adenomyosis, which is a more severe disease, make use, I mean, of extend cauterization. So this has an effect in the healing process. So I think that we have to agree that, it's not, the operation per se. I mean, that it's, what type of operation, what you used during the operations that makes the difference in the time that you have, to wait. And also we all agree, it seems, that you have, to see afterwards the healing process in the uterus. So giving, let's say, a general instruction, wait 4 months or 6 months or 8 months or 1 year, because there is no proof of that. Just for me, the most important thing is just look to the operation, to the extent of the operation, what is used during the operation, and what is the healing process afterwards, before advising the women to go for a pregnancy.
Thanks for your answers. Dr. Koray, let's move on.
Yeah, next question.
The last two questions.
Yes. Dr. Keckstein, please. how common is adenomyosis in patients with endometriosis?
Very, very, very common.
Yes.
Very common when we come back to our beginning, to my first question. And there is, let's say, a big group of patients, probably adenomyosis is the first pathology, followed by other types of endometriosis. So there is a coexistence, but there are some patients with normal uterus and severe endometriosis. For that, we do not have enough data. If probably it's in the molecular plane, where we have to look at the micro information about the cells and the behavior of the cells in the basal endometrial. But I would say there's a coexistence of more than 80%.
Thank you, Dr. Keckstein. Dr. Grimbizis, please.
It depends on what we are looking for, and also, in the different groups. It seems that, everybody agrees that in cases of endometriosis, you have, some findings of the so-called adenomyosis in those patients. But I prefer to change a little bit the discussion, because we are discussing about, let's say, adenomyosis, and sometimes what we are seeing is, some changes in the junctional zone. For me, any change in the junctional zone does not mean that you have adenomyosis. Junctional zone is a different entity, and you have changes related to endometriosis. You have an increase in junctional zone, inner myometrium, let's say in general. But this might be either, let's say, stage 0 adenomyosis or simple myometrial hyperplasia, and this means for me an endomyometrial dysfunction that might affect the infertility. It might progress, let's say, to adenomyosis, but it's not necessarily adenomyosis. So this is the one, and this is important.
But this is a definition.
Yeah. So I think that, but, we have to discuss, because there are a lot of, discussions. If we have to consider this, adenomyosis.
Yes, of course.
It's different. So this is the one. On the other hand, I fully agree, with Jörg, that, there is an increased proved prevalence of adenomyosis, with strict criteria, in endometriosis patients. And this makes a difference in the different publications. For example, CANS, which one of the first ones, it's a French group, support that in 80% of cases of endometriosis, you have changes in the junctional zone, which is, but all these cases are adenomyosis. There is a big discussion. Of course, we can expect an increased prevalence, and we have to treat those patients differently. For me, an indication to look for adenomyosis in infertile patients is the presence of endometriosis.
Thank you, Dr. Grimbizis. And Dr. Pistofidis, any more comments?
Well, I think that I agree with my predecessors. I think in my experience, I'm talking about my practice, up to 90% of patients with adenomyosis can have endometriosis. I think there are more patients with adenomyosis, in my understanding, who also have endometriosis. There are less patients who have endometriosis of the type of ovarian endometriomas or peritoneal endometriosis, who also have adenomyosis. There is much less of that proportion. But patients who have deep endometriotic nodules very frequently also have adenomyosis.
Thank you, Dr. Pistofidis. Yes, Ahmet, last question, please.
Yes, last questions. Our guests are very exhausted, but last questions. What is the coexistence of the adenomyosis and endometrial cancer? Is there any existence with adenomyosis and endometrial cancer or not? Dr. Keckstein, what is your opinion?
There is a coexistence, but the data are very difficult, because very often I have personally a few patients where in histology you find a continuous growth from the endometrium into the adenomyosis. But this is not clear where it came from at the beginning, from the adenomyosis. And when we think about the idea also of Grigorios, who says if there's an underlying very superficial endometrium adenomyosis, is this adenomyosis or not, or is this a disturbance of the endometrial architecture? So at the moment, my personal experience is there is a coexistence, but it's very difficult, and it's very important that the pathologist gives you the information that there's a continuous growth between endometrium and adenomyosis, and very often you cannot find this.
Okay, thank you very much. Dr. Pistofidis?
Well, in all my experience, I had 2 cases of adenocarcinoma in patients with adenomyosis, and this was a coincidental finding that was picked up in the biopsy. So we are talking about a very rare situation. On literature, there is a relative risk which is about 2.3% more than the normal population in women with adenomyosis, with adenocarcinoma, and funnily enough also for thyroid cancer. I mean, these seem to be 2 malignancies that seem to happen more frequently in women with adenomyosis compared with the general population. So there is some connection, but there is always connection in all these inflammatory diseases. There is always some kind of higher risk to find coexistence cancer. I don't know what's causing it in case of adenomyosis, but there is definitely, it seems to be a higher risk in these particular patients. So one has to be careful.
Okay, Dr. Grimbizis?
I will start from another adenomyotic entity, which, we ignore a little bit during the discussion. You know that there are the so-called adenomyotic polyps, which is an entity that in ultrasound you cannot differentiate, from the normal polyps, but you have it in histology. So in those type of polyps, that it's, let's say, a form of adenomyosis. You have the typical and the atypical forms. So if you have, an adenomyotic polyp, you have to look very carefully. Not you, I mean the pathologist. If it's, let's say, typical or atypical. And if it's atypical, in 10% of the cases, you have either hyperplasia, typical hyperplasia, or adenocarcinoma. And you have to be very careful also not for the coexisting at the same time of the operation, but in the future development, of cancer in those type of patients. So this is a special type that you have to look very carefully and to treat in a very specific way. So if you have an adenomyotic atypical polyp, because we cannot see the ultrasound, but you see it later in the pathologic report, then you have to go back, to remove also, part of the myometrium and to take biopsies, from the endometrium all around, to exclude either atypical hyperplasia or maybe a coexisting cancer. So this is important, and this has to be mentioned, that there are publications on that we did also review. So concerning the, let's say the risk of endometrial cancer, actually, we try to review this. There are not hard data, but it seems that probably there is an increased risk. I mean, of adenocarcinoma in cases of patients with adenomyosis. We cannot say if this started, from the basal endometrium within, I mean, within the myometrium or from the endometrium. And, if you have coexisting in 2. As far as we tried, I mean, to see what existing in the literature, it's not still clear. So it's an open issue. Probably we have to take care of these patients in a different way in the future. Probably there is an indication for adenomyotic patients with diffuse adenomyosis after completing, their, let's say, parenthood, just to see the option of, let's say, a hysterectomy, laparoscopic hysterectomy.
Thank you very much for all of questions. And Really beautiful questions and beautiful answers to your contribution. Dr. Engin Oral, before closing the session, do you have any comment or any questions to our panelists? I think Dr. Engin Oral couldn't hear us.
Maybe Dr. İnceboz might want to say something.
Yes, maybe Dr. İnceboz, Dr. Engin Oral will say something, the last words or last comments about the session or panel. I think they cannot hear. Okay. We would like to thank all of our panelist professors for their information about adenomyosis and their enlightening answers about adenomyosis. Before closing, we would like to hear the last words and wishes from our guest speakers. Please, Dr. Keckstein, your last words, and we all thank you for your answers about this issue.
Thank you very much for all listeners and all participants to this webinar. I enjoyed to be part of the faculty, and I enjoyed also the commentaries of my co-speakers, which make everything very interesting also for me, and the discussion will give us the new task what we have to do in the future. And thank you for the society organizing this webinar. Great job, and we should do this in future more often. Thank you.
Thank you very much for your contribution. Dr. Grimbizis, your last words, please, your wishes.
First of all, I would like to thank you for the invitation. You know, it is really a honor for me to participate. You know, we had the opportunity to meet each other, in Istanbul, last year in the SG regional meeting, and really I enjoy, let's say the discussion. And for all of us, I think it's an opportunity not only to review this, but also, to have some new ideas about the management of this, very difficult issue. Second, I would like just to congratulate, you, the society, and personally you both, for the type of, the webinar that you selected to do, because it's really, very interesting not to have only lectures, but also discussions. And we see that at certain points, there are some hot spots during the discussion, which I enjoy a lot, because this is science and this is the way just to go on. Thank you indeed from my heart for giving me the opportunity to be part of this panel. And I would like also to thank my co-speakers, Jörg Keckstein and George Pistofidis, for his contribution apart from you. Thank you very much.
Thank you very much for everything. Dr. Pistofidis, please, your last words before closing.
Yes, I also want to thank and congratulate your society, like Professor Keckstein said earlier, because you're doing a great job, you're very active, and it shows by, collecting these speakers tonight to talk about this pathology. And I want to say that adenomyosis is an incomplete and a developing scientific problem. We still have to learn a lot about how it happens and how to manage it. So I think such meetings are extremely important, because every time I participate, I learn something new, and I can implement it in my practice and make myself better. So thank you very much for giving me this opportunity, and I wish everybody a very fruitful and very successful future, and hope to see you soon in a different occasion. Thank you very much.
Okay, I again thank all of our guests for their extraordinary information about adenomyosis and their answers about this issue. Dr. Koray, please close the session.
Thanks to all our speakers for their precious contribution. We were very glad to hear from you. Thank you very much.
Thank you also. Bye-bye.
Thank you very much.
Bye-bye.
Good night. Bye-bye.